Good evening all. I am Dr. Chaitali Nikam, heading Infectious Diseases section at Thyrocare, welcoming all the participants to the series of webinar conducting in collaboration with Haystack Analytics, IIT Mumbai. So this agenda of this particular topic is TB. So as we all know that some of the biggest challenges in drug-resistant tuberculosis treatment are low compliances, high defaulting rate, and physicians are not able to give the right drugs because of a delayed and incomplete diagnosis. The programmatic management of drug-resistant TB, that is PMDT, in line with global recommendations, has introduced several regimens, including newer drugs for DRTB. However, personalized treatment and apt regimen will be effective only when the drug susceptibility profile is known across all the group of the drugs in TB management. In the current webinar, Dr. Sumalata will be discussing the various case studies for DRTB and also presenting through few of the technologies. I welcome Dr. Sumalata. She is having 10 years plus experience, and she's a civil surgeon specialist posted at the State TB Epidemiologist in State TB Training and Demonstrator Center in Hyderabad. She is national level and state level trainer on technical operational guidelines of PMDT. And she received multiple awards for the best services in RNTCP or NTP, which was priorly known as RNTCP for the year 2018, 19, and 2020. She is having excellent multiple research paper in the peer-reviewed national and international journals. I welcome Dr. Sumalata. Besides this, we are having our another speaker, who is Dr. Jay. Dr. Jay is consultant chest physician at PD with one of the renowned hospital, tertiary care hospital in Mumbai, that is PD Hinduja Hospital and Medical Research Center. He is having 10 plus years of experience in the domain, and he's keen and interested in the MDR-TB with multiple national and international publications, including the first cohort with the bedaquiline from India. He's an organizing secretary for the National Update in Respiratory Medicine for 2011 to 2014, and multiple research paper in the peer-reviewed and national and international journals. I welcome Dr. Jay. You can ask your question via two ways, by raising your hand or in chat box. So for chat box, you can put your question in the chat box through the session. Mention the speaker's name along with the questions when you would like to be asked, and moderator will announce the questions one by one. Either you can raise your hand if you want to ask a question, and moderator will call your name to ask your question, and kindly unmute yourself before asking the questions. Answers which are unanswered due to time constraint will be shared via email. Now I would like to request Dr. Sumalata to start the webinar with her presentation. Thank you.
Good evening, everybody. Thank you, Dr. Chaitali, for those kind words of introduction. So we were, in the view of pandemic, we are conducting many virtual sessions where we are seeing, we are exchanging knowledge on many platforms. And thanks to Thyrocare, who had, provided me this opportunity to share my experience with genome sequencing and how it was in the program as I work in the public health program and also a consultant. So I can see the both perspectives. So the topic was labeled as, is it a boon or a bane? So coming to the introduction, we know tuberculosis was discovered by the Sir Robert Koch, and he received a Nobel Prize for that. And from 1982 to 24th March till date, we have been fighting with this disease at all points of time, and with the advances, and we are coming with newer drugs, newer technologies, early diagnosis, early treatment. So many modalities have come, but still we are fighting. Now India has geared up its action towards TB control, and we are going for a TB elimination. So we have got many dramatic and drastic changes in the program involving all the sectors of the community. And we also know Rene Laennec, the one who invented the instrument which every physician uses. And the very important part in the diagnosing of a pulmonary TB in NTP, that is National Tuberculosis Program, previously to the RNTCP, and now in NTEP. So the X-ray, the radiology, this was discovered by William Conrad Röntgen, and all these have to be remembered because of them we are able to make furthermore advances. And today's topic, genome sequencing, was discovered by Frederick Sanger, and he also received Nobel Prize for this invention. We all know that there are many great personalities who were victims of tuberculosis, and they are well-known victims. Statesmen like Nelson Mandela, Kamala Nehru, mathematicians like Srinivas Ramanujan, poets like John Keats, very Indian first doctor, Dr. Anandi Joshi, Munshi Premchand, Amitabh Bachchan, and South Indian actress Suhasini, all have been victims of tuberculosis. So before I go into this topic, I just want to share my experience with the case and how genome sequencing has changed in managing that particular patient in terms of treatment. So he is a 30 years male from Tekulpalli village of Khammam district. He works in a cement factory. He had been working for 12 years. So this working in a cement factory and the period of exposure also is important for us in understanding the relationship between the silicosis and silicotuberculosis, which is very commonly associated. And fever since 1 month and cough with expectoration since 2 months. Excuse me, my slide is not moving. Yeah. So this particular male came with the chief complaints of fever for 1 month, high grade and intermittent nature, and evening rise of temperature subsiding with medication. And then he had cough with sputum from 2 months, and which had yellowish discoloration, and it was occasionally blood tinged. And sometimes it was a copious quantity of sputum he was expectorating, and he had shortness of breath. But there was no history of wheezing and no history of orthopnea, paroxysmal nocturnal dyspnea, palpitations, or any swelling in the both limbs. He had a history of night sweats, generalized body pains, joint pains. Past history, we did not had any asthma, hypertension, or diabetes. He was not a cardiovascular disease person or a chronic kidney disease. But he had similar complaints in February 2021, for which he took treatment in a local hospital for pulmonary tuberculosis and stopped the medication once his reports showed he was normal. There were no documented history of surgeries or drug allergies. Personally, he was taking a mixed type diet and his appetite decreased. He was having inadequate sleep due to cough. bowel and bladder habits were normal. He was alcoholic since 11 years and had a habit of tobacco chewing since 6 years. There was no significant family history. His vitals showed 26 respiratory rate 26 per minute with abdominothoracic type of breathing, and temperature was 100 degrees Fahrenheit. His body mass index was much low. He was cachexic and very, there was a evident loss of weight, and BMI was 14.7 kg per meter square. Excuse me. BP was 170, both supine position in both the arms, and pulse was in normal. As the patient, he suffered cough and fever and was admitted in TB ward for further evaluation. So when his respiratory system was examined, he had a poor oral hygiene because of his tobacco chewing habits, but he did not have any dental caries. But the lower respiratory tract had decreased vocal fermenters, breath sounds, and in the clavicular and infraclavicular region, and a dull note on percussion was also noted. And cardiovascular system and CNS were in normal limits, and JIT was normal. When we investigated that particular person, the X-ray picture was showing in the shown as seen in the picture, and the sample tested in the TrueNat was showing rifampicin, MTB detected, and rifampicin to be sensitive. The second, as per the program guidelines, the sample was sent to first line LPA on 25th of June 2021. He was diagnosed as RIF sensitive as per the program guidelines. He was started on a 4FDC, the regular HRZD regimen, and he was in the TB ward itself, and his symptoms got worsened, and we were waiting for the first line LPA reports. So the first line LPA reports took a longer time because it was a smear negative, and it had the culture grown, and that sample was done the LPA, and it showed INH CADG mutation along with the rifampicin resistance. Now understand the point that rifampicin was sensitive in the TrueNat, but in the FLLP it showed resistant, and we did a umpire reading in the IRL CBNAT also, it showed rifampicin resistant. But at the time, it was very difficult for a treating physician at the periphery to understand what should be the treatment offered, whether it should be a RIF resistant or a RIF sensitive. So at the same time, the DRTB committee has decided to send this particular patient sample to genome sequencing. Parallelly, we're awaiting for the results of the first line LPA. So then patient was started on all oral longer regimen after going through the entire pre-treatment evaluation test like a CBP, blood glucose, blood urea, LFTs, and ECGs and 2D echoes, then serum electrolytes, then thyroid profiles, then HIV markers, and HRCT also. Then we got his genome sequencing report, whole genomic sequencing report, which showed that the sample was resistant to isoniazid, rifampicin, streptomycin, ethambutol, pyrazinamide was inconclusive. So at that point, we decided that he is not eligible for either shorter regimens. He should be given all oral longer regimens where we do not have pyrazinamide in the regimen. So he was offered an all oral longer regimen with bedaquiline, levofloxacin, linezolid, cycloserine, clofazimine, and paradoxin as a supplement. So this decision was taken after we got a entire array of genome report of the genome sequencing, where the entire array of the drugs and their sensitivity pattern was known to us. So in this particular patient, it helped into us to understand whether the resistance, what type of resistance and what type of sequencing really helped in managing this particular patient. And he is right now doing good. So to understand better, what are the types of genes we have for every specific drug, and what are really picked by the program, what are not picked by the program. So in isoniazide, we do catalase peroxidase in CATG and INH reductase. So these two are already available in the program in the form of first-line line probasis. Rifampicin, RPOB genes are, that is the only gene that has been recognized in the CBNAT or TrueNAT or the first-line LPA. And sometimes we encounter with resistance inferred, where we see the wild type and mutation or corresponding mutation also is not present, or both the wild type and the mutation are not present. So sometimes these molecular techniques give us the information, but we do not specifically have an reason or evidence to go ahead with the management of the particular patients. So these are the few of the genes which are available. And for isoniazide, we have catalase peroxidase CATG and INHA for in first-line line probasis, and also rifampicin RPOB genes. For second-line LPA, it is RRS and EIS gene, and for fluoroquinolones, so gyrase A and gyrase B, which is seen in the second-line line probasis. Now, why genome sequencing is considered important in such a particular scenarios? It will help us to understand how these genes really work together to detect the growth, and how the development and maintenance of the organism is going to happen, and understand how gene expression is regulated in a particular environment. To study gene expression in a specific tissue or an organ or a tumor. And to study it in a human variation, and how humans relate to the other organisms. And it also helps and gives information about the development of cancer or susceptibility to other diseases or metabolism, pharmacogenomics, etc., etc. So now we saw how the drugs can be helping, how the resistance or sensitive pattern is understood by using the genome sequencing method. So DNA structures were discovered by Watson and Crick. They were identified it, and they were also awarded Nobel Prize for that. We also know is a DNA is a chemical substance, a chain of nucleotides where it contains a phosphate and a sugar and a nucleobase, which could be adenine, cytosine, guanine, and thymine, which are bonded by double and triple bonds. So this DNA sequence is a biochemical method which will determine the sequence of that nucleotide base that will make up the DNA. So that targeted DNA is our point. So how is it done? It is done in few techniques like clone by clone and shotgun sequencing method. Clone by clone is you replicate the whole genome and you understand the sequence. And shotgun, you will put it into the fragments and assemble the fragments based on the sequence overlaps. Now in PMDT or the drug-resistant TB, it is conferred by a point mutations, that is change in the single nucleotide of the DNA in specific target genes like RPOB gene or CATG gene or INHA gene or RRS gene or whatever is the specific gene. We are going to get the point mutation in specific gene targets. So targeted sequencing can be achieved through many methods like pyrosequencing, Sanger sequencing, as well as next generation sequencing. So next generation sequencing, it offers a promising for rapid diagnosis of DRTB when compared with the whole genome sequencing. So in higher user settings, it is now limited to national reference laboratories or a well-to-do intermediate reference laboratories. So this next generation sequencing will help in detection of genome sequencing variants to predict TB drug-resistant phenotypes, identifying the strain lineage and resistant mechanism for TB surveillance, recognition of genetically related strains for resolution of transmission chains. So what is the drawback with next generation sequencing in a public health perspective? It's a cost and its integration into the laboratory network, at least in the public sector. And we need a good training and skilled human resource, and we need an expert guidance to validate it. And So there are still mechanisms which are, thinking by the government that amplification based targeted next generation sequencing assays will from the sputum specimen are still in pipeline, and they will be integrated into other algorithm. So when we come to whole genome sequencing, you can see the chart here. It has both two parts in the wet lab and the dry lab. When a genome, you get a DNA extracted from the sample you get, and that fragments are the short reads. So till that part, I mean, the libraries of the DNA are being prepared at the wet lab. And once they are transferred to the dry lab, the quality checks will be made, and you do the genome sequencing, and you can see a screenshot that it will be, the map will be read to see the reference genome to understand the whole genome sequencing. So the report of a whole genome sequencing is a sample report which I'm showing you. It will be based on that result we get, the genome sequencing, we get whether that particular drug is sensitive or resistant, and that will actually help the patient in terms of managing whether the drug has to be given or to be avoided. Second is the next generation sequencing, which we already talked about. So here it is a more simplified method from a whole genome sequencing, and this has less cost and less less cost when compared to the whole genome sequencing, and this will be more of a use in a management of drug-resistant TB. So they also have a preparation of the library of the DNA, and then the sequencing will be done, and that is informed. And so the bioinformatics are done, and that will reveal the sensitivity or resistant pattern. Pyrosequencing is another method. It also detects a known mutation. So we are doing the targeted one, and it is targeted sequencing in Illumina. And this is associated with DNA is isolated and fragmented, and its special adapters are converted into a single stranded. Then their PCR is run, and then pyrosequencing is done. So this all happens in a pyrosequencing. Sequencing in a nanopore is a electrical current. It changes. Measure changes in electrical current as DNA is passed through a nanopore by two pairs of tiny gold electrolytes. So these electrodes record electrical current perpendicular to DNA strand. As each DNA base is structurally and chemically different, each base creates its own electronic signature. So this is how the sequencing done in a nanopore. So I'll be glad to take these questions, and thank you very much, Thyrocare, for providing this opportunity to talk and share my case and this thing. And from the public health perspective, what I have seen, the genome sequencing so far we have done for a few rare cases where our molecular diagnostics were not giving enough clue. But in such cases, the genome sequencing helped in management with the correct regimen. But as the program still thinks that genome sequencing can be used for the surveillance purpose rather than the patient management system. So we are seeing more and more evidence so that genome sequencing can help in management of the DRTP patients. So with that, I'll end the topic, and thank you all for patience listening. Any questions, I'll be glad to take. Thank you, Chaitali.
Yeah. Thank you, Dr. Sumalata, for such an informative session. Mainly the gene expression related issues which was narrated by you was totally, brainstorming and given new information to us. Also, whatever the incorporation in the guidelines and what are the drawbacks of the present assays that you had mentioned pretty well, and also about the technologies. Also for sharing such a classical case where you have actually made a personalized treatment and, help the technology for the well-being of the patients. So I would, there is one question, but at the end of the session, we'll take the questions together. So now I request Dr. Jai to please carry on with his presentation. Welcome, Dr. Jai.
Thank you, Chaitali and Thyrocare for having me. Dr. Sumalata has covered a lot, most of it very well already. So I'll just be going in through a brief about uh, genome sequencing and other tests that we have. And so as we know, TB diagnosis has moved leaps and bounds over the last century. It's, from phenotypic tests like smear microscopy and solid and liquid culture. Now we have genotypic tests that have come into play and almost become standard of care, especially in diagnosis of drug-resistant TB. The standardizers of procedures is still set up, and in phenotypic tests, correct performance of DST requires several steps such as origin of resistance and interpretative criteria. As we know, the critical concentrations are a bit of an arbitrary criteria. It's not like an MIC. Dosage and stability of the incorporated compounds, antimicrobacterial activity of the incorporated drug, and interpretation of data and results and data reporting, which is why you could have a lot of variation between labs, etc. So, which is why genotypic tests are a lot more accurate and in many cases even easier to perform. They certainly have a faster turnaround time. So, what are the tests that we have? As we know, the most common test is the Gene Expert, which we have, which is almost a point of care test now. It's a turnaround time of only 2 hours with a cartridge-based test. It detects tuberculosis as well as rifampicin resistance, and it detects regions of mutations, but may not pinpoint a specific mutation, and may also detect silent mutations. As we know, it needs about 130 bacilli per ml of the sputum compared to, say, culture, which needs 10 bacilli per ml. Of course, now we have the Gene Expert Ultra, which can detect up to 6 bacilli per ml. And we have Expert XDR, which now is, I think, launched at Hinduja, which can detect almost like an LPA. So LPA line probe assays, earlier called as the Hain test. We have the first and second line test, and it detects MTB as well as resistance to HR, fluoroquinolones, and second line injectables. It is more reliable in smear positive pulmonary samples and pus. So the yield in smear negative samples, unlike in Gene Expert, would be a bit lower. It can provide us with high level as well as low level resistance mutations. And they are just some examples. So rifampicin, RPO beta. So if you have 531L or 52060, they are probably high confidence resistance markers, while some of the others will be low resistance. Similarly, GAIR-A in fluoroquinolones with 94G are high confidence, while some of the other markers as we have below are low confidence. And CAT-G along with INHA is a high confidence marker, while INHA C15T alone is a low confidence marker. So accordingly, we can probably look at some places that whether a high dose of the drug, like say high dose INH or high dose of the fluoroquinolone, might be useful. Other genotypic tests, one of the advantages of course, Gene Expert was that it has a very good yield in CSF and lymph nodes. Of course, it has poor yield in pleural fluid. Some other genotypic tests, if you look at spirosequences, this looks at specific mutations, and again, good yield in the BAL as well as post culture, and also very good yield in CSF. Next generation sequencing, as we've already looked at. And finally, what we are talking about is whole genome sequencing. But each test requires increasing amount of expertise. They need specific places. So except for the Gene Expert, every other test that we've talked about, it's not an easy to do test which a layman can do. We need a good amount of expertise. We need to know which mutations clinically correlate with resistance, and interpretation according to databases. So it's not a very easy thing, but as more and more as the science evolves and it becomes more and more available, it should become easier for all of us. So about whole genome sequencing, TB whole genome sequencing diagnosis rapidly shows exactly affecting Mycobacterium tuberculosis, including its complete drug resistance profile. and thus allows clinicians to identify the best treatment regimen to combat the disease. And it can, we get this result pretty quickly. Like if you wait for culture and DST, you're going to wait for anything between about 6 weeks to 8 weeks. And this turnaround time is almost just 10 to 12 days. So you're saving almost 5 to 6 weeks before you get the exact answer, and you can tailor your regimen. The implementing of this genome sequencing will can benefit the National Tuberculosis Program, providing data for surveillance of resistance to anti-TB drugs. For example, we have newer drugs such as bedaquiline, delamanid, linezolid, where the resistance levels in the community as of now are quite low, but it can be tracked whether certain areas or certain pockets of the country are showing an increasing resistance and what can be done about that. And it's an important information for high burden countries to set TB control strategies and priorities. So advantages, as we know, it detects MTB, it can detect mixed infections with mixed strains, say sensitive as well as resistant strain. It gives a complete genotypic DST to almost 18 drugs, which probably even most phenotypic DSTs will not be able to give you. It has, as I mentioned, a rapid turnaround time of 10 to 12 days, and it is cost effective as of now compared to culture and DST. I think the whole genome sequencing costs about 3,000 to 4,000 rupees, while culture alone will take about 2,000 and the DST will be another 10 or 11,000. So it's about 12 to 14,000 rupees that you might have to spend for culture and DST. So what is the technology for whole genome sequencing? Again, we have sample collection. There is culture enrichment followed by DNA extraction. We have a pre-sequencing preparation, sequencing. Then you have data analysis, and finally with report generation, which they are doing it. Thyrocare is doing it along with Haystack and IIT. So this is kind of a sample report where you have the various drugs mentioned and whether the presence of drug-resistant mutation is detected or not. And similarly, you get this kind of a figure as well, where you can see which drugs are sensitive and accordingly tailor your regimen. So question is, it is designed for scale, it is safer. It's called reduced sampling handling and culture handling. Safer for the lab team because of the operating protocol. Automation of lab flows. Automation of lab flows and liquid handling is a key capability, and bioinformatics and real-time digital data. It originates digital data, auto feed into the Nikshay portal, so the doctor doesn't have to feed it separately, and data-driven public health monitoring, treatment and supply planning opportunity. So we also need to look at clinically relevant mutations. So every mutation that is there will probably be detected based on the whole genome sequencing, but which of them are actually clinically relevant, which of them are silent. So once we have that database and we match that up to our report, so blindly just looking at the presence of or absence of a mutation, whether that really should change your regimen or not is important. As I mentioned again about the silent mutations. It can provide greater resolution than conventional genotyping for investigating recent TB transmission and drug resistance. One-stop source for curated genotypic and related metadata from MTB strains, and transitioning using total genome sequencing as the standard method for TB diagnostics by providing antibiogram of 18 drugs within 12 days at an affordable cost. And if I'm not wrong, I think in the UK, they have already made genome sequencing the standard of care for all TB cases. Might not be the way to go in India right now because of our huge load, but definitely if you have a drug-resistant case which has been diagnosed, say on expert or LPA, rather than waiting for culture, surely we can go ahead with genome sequencing and get a quicker result and probably even a more accurate result. Thank you. If you're going to take any questions on this.
Yeah, sure, Dr. Jay. I would like to thank Dr. Jay for such informative presentation and enlightening with the technologies, mainly emphasis of the tailoring the regimen and how you use our whole genome sequencing results in it. So there are 4 questions in the question box, so I'll just go one by one. So first question is, what is the sensitivity of TrueNAT? So, Dr. Sumalata, are you there to take this question, or should I answer?
Yeah. I'll be glad to do it.
Yeah, please.
Yeah. So TrueNAT sensitivity, when compared with the Gene Expert, in one of the few studies conducted in India, showed much higher than Gene Expert. So it's pointing to approximately 96%, whereas Genome, Gene Expert with all the technologies, with all variety of the samples, it's amounting to around 89 to 90%. So that's why the decentralization mechanism was taken up by the government for utilizing TrueNAT at the most peripheral level, because it doesn't require much infrastructure also. So that is the sensitivity with the TrueNAT.
Yeah. So just adding one point to Dr. Sumalata's answer. So we have discussed about the Gene Expert, but then gold standard for the culture, which is supposed to in TB is supposed to be the culture, and sensitivity for TrueNAT is about 86 to 90% to that, as well as with the specificity of 99%, which is equivalent to expert. Also, there are so many publications which have detected the sensitivity and specificity based on the smear status. So if smear status of or also the sample type, as in sputum always have a good bacillary load, and it's easy to detect as compared to extrapulmonary sample. So there it definitely varies.
Yes.
So next question is, how to treat a case of MDR-TB with hypo or hyperthyroidism? Who would like to take this question?
So yeah, I can take that. So
yeah.
So if you have hyperthyroidism, basically, if you look at today's now the latest WHO guidelines, so ethiramide and PAS are anyway going to be a group C drugs. So your main drugs, the recommended regimen is an oral regimen where you're going to start with something like bedaquiline, fluoroquinolone, you have linezolid, cycloserine, and clofazimine. And if you cannot use one of these, that's when the ethiramide, delaminates, etc. come into play. PAS almost very low on the list. So if you still do have to use one of these agents, I think you can still be manageable with the regular monitoring of your thyroid function, and making sure that the thyroid medications that taken, you might have to increase the thyroid L-troxin or Thyronorm dose based if you're a hypothyroid, in case you're taking either ethiramide or PAS, but no other drug really should be interacting. But as I said, I know they were initially when the all oral regimen wasn't in place, these were one of the two main drugs, but right now they are quite low on the list, so really shouldn't be made, too much of a problem. But always involve your endocrinologist in that, so any dosage changes, etc., can be looked into.
So this question was from Dr. Suresh Kumar Mishra. Now, next question is from Vijay Chauhan. So does whole genome sequencing identify NTM species?
Can I take that question?
Yeah, sure.
So whole genome sequencing can be done for NTM also, for many diseases as such. So today we were talking most of it tuberculosis, but there are many, because of the clone methods or the shotgun methods, it can be taken even in the non-tuberculous mycobacteria, in those NTM speciation also. So yes, it is possible.
I guess any infectious diseases you can probably involve it where you are suspecting resistance, including say HIV, etc. So it depends on your target and how you look at it.
Right. So next question is why whole genome sequencing still considered only for surveillance application in India when in countries like UK they have deployed this technology in the program. 3-4 years ago. Should this change, or it is too early for India? So would like to have both of you just need your
I think the UK,
expertise opinion in this on
I
this.
think UK one is population is, I mean, very low compared to even the TB rates are very low. So at that level, to have a whole genome sequence for every TB isolate might be feasible. I'm not sure with our population and our TB rates whether as of today it will be feasible. I know in specific conditions it might be, and we still, I think, as we get more and more centers and more people doing it, eventually it might be, look at the standard of care thing. But of course, I don't think we have enough people even doing it. So just the labs are going to be loaded and you'll be having delays if you are going to get every sample to the whole genome sequencing right now.
Yeah. To add to what Dr. Jason has mentioned, see, when we want to, so over the period of, when we see the programmatic management of drug-resistant TB over last few years, there are so many changes coming up. And in this very 2021 guidelines, there was a specific mention about genome sequencing in specified laboratories, where even the government is thinking for a special scenarios, at least for the DRTB cases, where genome sequencing would help. But keeping in the point of its cost and the infrastructure needed and the trained personnel needed to interpret this test at all the public sector labs is a challenging. So now that is limited to very good laboratories and the national level reference laboratories. So probably in the very future, maybe this can be taken up through entire country as taken up by the developed countries.
Thank you for such a wonderful answers from both of you. Now, next question is from Dr. Narayan Pradeep. So there's a history of irregular treatment, history of exposure to second-line drugs, and TrueNAT positive and rifampicin resistant and gene expert MTB not detected. How will you proceed for such kind of discrepancy test result patient?
I'm guessing if, you've ordered the test because you're suspecting there is TB. And it's possible if you've given two separate samples, if the second sample wasn't good enough or for whatever reason it's not detected on the expert platform, maybe you can repeat one and see. But I would, if you're suspecting active TB, I would not disregard the RIF resistance and I would go ahead and treat it as MDR.
What about your opinion on this, Dr. Sumi?
We do encounter such cases, very, lot of discordance when we do it in the expert and also in the TrueNAT. So it is always, as a clinician, I believe we do not read the reports. We do understand the clinical picture of that particular person, how he is doing with the first line drugs or how he will be doing with the second line drugs. So there we take a collective decision whether this particular patient should be labeled as a RIF resistant and continue the treatment. So we have got a few examples like that. So we have, as per the guidelines, the patient was diagnosed as RIF resistant in some periphery of the state. And when it came to the intermediate reference laboratory, the sample was tested sensitive. And the patient was improving very good with the second line drugs. Now, this molecular test again cannot change that based on this molecular test conducted at the reference laboratory. If we need to change it, it is a lot way to, to explain the patient the genetic test we have done, the molecular test offered. And also it is very difficult to explain to move the patient from the second line drugs to the first line, or in fact, sometimes no TB also. So this is a little tricky in case of molecular tests offered, both in line probe assays, TrueNATs and CBNATs. Now here, most of the time, the center's physician decision or the clinician's decisions plays a very good role in determining whether he is resistant or sensitive. So that really helped, because we encounter lots of such cases in many parts of the state here.
Okay, thank you. Next question is, how much bacilli in the sample necessary for sequencing? So I would like to take this question as we are looking for the samples, basically pulmonary to go ahead with, and generally we do culture the samples or we just expedite the load of the bacilla into the sample, because whole genome sequencing requires good amount of DNA, good quality DNA, and which is required to pass the QC and the library which is required for whole genome sequencing. So it's always seems to be smear status positive, who can, the samples which can grow well in next 5 days, which will expedite our turnaround time. And definitely smear status absent and extrapulmonary samples will be challenge for whole genome sequencing. Next question is from Dr. Vijay Chauhan. So what sort of tissue sample which do not respond? Okay. What sort of tissue samples can be processed through genome sequencing? Is it useful even in extrapulmonary cases which does not respond to conventional treatment? So who would like to take this question? Dr. Jay, Dr. Sumalata?
I think pulmonary samples are probably, pulmonary and smear positive.
His question is what type of, what sort of tissue samples can be processed through whole genome sequencing?
So I'm not sure about extrapulmonary, how would you generally process them? I know sputum and bile, you can definitely do that, but I'm not sure.
So as per me, what he wants to ask is what type of sort of tissues may be the affected areas where you think that, it's a site specific tissues would be recommended.
Yeah, so like example, I think lymph node or, pleural fluid or CF,
Yeah.
Those be processed.
Yeah.
So
that's the end of
Chaitali, you can tell us if you...
Yeah, so that's what. So I've already replied. I've said stating it's site-specific tissue samples. If it's now there is one question. So question and answer sessions from chat box are over now. Now there are few questions which are in chat box. I'm taking important of those. So what are the advantages over conventional DST, which has been asked by Dr. Aniket Gangude?
So one is, I mean, as you know, the turnaround time is much less compared to conventional DST, which is going to take almost 4 to 6 weeks. This is 10 to 12 days. Second is conventional DST is a little bit arbitrary, as you know, it's based on critical concentrations and not MICs. And, we really don't know whether, for example, when you take moxifloxacin, if you take 0.25, you take 0.5, does it mean high dose, low dose? We really don't know. So if you look at probably genotypic, like whole genome sequencing, you can actually get the exact mutation, which might tell you whether it's a low level, high level mutation, etc. So I think those were the main thing. And even cost wise, at the moment, I think it's much cheaper than conventional DST.
Next question is from Dr. Suresh, who would like to know how to manage the treatment of MDR-TB, pregnant woman, and the dose management. This is for Dr. Jay.
Pregnant women, so definitely one is that, I mean, treating the TB is for the mother is the paramount thing. Of course, avoid second line injectables because, I mean, one is that they are not no longer recommended as first line treatment, and it can affect the fetus as well. So that would be out. Even bedaquiline, I'm not sure at the moment. I'm not sure whether it's allowed amongst in pregnant women, but most other drugs we can use and to get a regimen of 4 to 6 drugs, which would include your linezolid, your fluoroquinolones, clofazimine, and other drugs as well. So main thing would be, I think, avoiding your second line injectables. Second is if it is early, if the early in pregnancy, like within the first trimester or example that way. So I think we have to at least offer to the parents of medical termination of pregnancy. And if they still insist on having the pregnancy and continuing with treatment, you provide the best drug combination that you can provide, keeping the fetus in mind.
Okay. Thank you very much. And Dr. Sumalata and Dr. Jay would like to glad and happy to tell you that chat box is flooded with the appreciation for your presentations, and all the participants, around 100 and plus participants, are congratulating both of you for your nice and informative session, and as well as question and answer session. There are few more questions in line, and I would like to inform the doctors that this will be taken up offline and emails can be sent to them for their questions. I'm thanking both of you, Dr. Jay and Dr. Sumalata, for taking part so actively in this webinar. And thank you all the participants who have their patience listening. And I'm concluding this session. Thank you very much.
Yeah, thanks, Chaitali. Thank you for having me.
Thank you.
Thank you, Dr. Chaitali, and thank you, sirs. And it is thank you, Thyrocare, for giving this platform.
Thank you.